Okay, good morning, everybody. Uh, we left off last time with the bacterial infections with the circulatory and lymphatic. Now we want to shift gears a little bit and think about different types of viral infections. There are a handful that we want to discuss as we move through uh, this section of the chapter. So initially, we've got a couple of images here. This first image is a patient exhibiting Burkitt lymphoma. It's the result of infection with Epstein-Barr virus, and there are various things that set the stage for this to occur. It's not, I guess I would say, not a common occurrence with that. When we think about this, Epstein-Barr is a type of herpes virus. We'll see some details here in a minute with the table, but it's human herpes virus 4. And there's handfuls of things that we can see with this. More commonly, something that many might relate with is infectious mononucleosis is the result of Epstein-Barr virus. There is another that has potential to cause mono-like issues as well, but Epstein-Barr is one of the main players. So there are circumstances that set the stage for development of Burkitt's lymphoma, which are cancerous situation, where we see compromised situations. HIV sets the stage for that, or other immunodeficiencies for people to have this occur. So over here we can see monocytes that have been infected, the infectious mono. So these lymphocytes with the vacuoles, these little holes within there, which is irregular. So shift over. It's a little bit different working from a different computer this morning. So here, this next image is shifting over slightly. Cytomegalovirus. It is also another type of herpes virus. It's a herpes virus type 5, or human herpes virus 5. And it also has the potential to target individuals that are compromised. It's definitely more likely to see issues with that. So HIV or other compromised situations, we can see other circumstances with organ transplants, kidneys that have been transplanted. Almost always those individuals that have received a kidney transplant wind up developing cytomegalovirus. And a lot of it is the anti-rejection drugs that lower the immunity in these individuals, that opens up avenues for cytomegalovirus to infect. It is something that is relatively common. It's estimated that, by the time we hit adulthood, upwards of 50% of us have antibody against this. With that said, unless you're, compromised, typically asymptomatic or very mild type of infection is exhibited with a little bit of fever or something like that, but nothing really that's that pronounced. It's more so, like I said, if you've got compromised situation. So there are a handful of other viruses that we want to think of as kind of hemorrhagic viruses, hemorrhagic fever, and we'll touch on those here in just a second as we shift over to the table. Just following through this PowerPoint before I jump and share a different screen. I want to hit Ebola. This is something that is definitely on the radar of people, I would say. Something that lots of people have heard about, know about, and probably are terrified of. It causes all sorts of various issues that have probably been described quite graphically some of which is accurate, and some of it is a little bit embellished, thanks to things like the hot zone, and that's okay, because it does kind of lend awareness to some of these situations. So uh, it is a here we've got this electron microscope or microscopic image of this virus uh, here, and it causes, various, like I said, issues with this. We think about, fever, headache. It's common to think about bleeding, and you've probably heard descriptions of, bleeding out of any orifice, bleeding, right from through the skin, it appears, and highly contagious. Contact with these fluids sets the stage to almost ensure that you're going to contract it as well. So there's big issues with healthcare workers coming in contact with this, where they have, without extreme precautions, high rates of contracting the illness. And we think about, working with it in laboratory situations. It's a biosafety level 4 pathogen. So, the spacesuits with air being piped into them and things like that to ensure safety. If you think about some areas where this virus would be found, the potential for that in a clinical situation is potentially non-existent, and that sets the stage for definitely for concern and, potential for it to spread. So this next image is an image of HIV. It's budding out of a lymphocyte, so it's being released from the white blood cell T4 or T helper cell, and you can see numerous viral particles being released as they were in there replicating. Sorry, flipping back and forth. So this image, we will get here in just a second to a table and describe some of those details that we've in the chapter have kind of glossed over briefly. But quickly, this map shows prevalence of HIV a few years back, 2015, among adults or people aged 15 to 49. I don't think I would call a 15-year-old an adult, uh, but there you go. Global prevalence, 0.8%, which seems like maybe not so much, but then we start looking in other areas like East and Southern Africa, West and Central Africa. These are, Africa is huge for high levels of HIV, and we see 7.1 and 2.2% respectively. Other areas, less than 1%. As far as prevalence goes. So big concerns with this, and huge amounts of population at risk or infected in some of these areas. So definitely concerns, and it is a global concern. It doesn't matter if you're in areas where the prevalence is relatively low. It still is something that should be of concern. So this figure is initially seems a little bit daunting as you look at this. There's a lot of stuff happening on here, but it's I'll walk you through this, and it's not too difficult once we move through here and see some of the details. There's a handful of things happening, and I want to point out real quickly before we get going into it. As you look at the x-axis, we start off with the initial infection here at time 0, and we're expressing this stuff in weeks. Then we've got a little hatch bar right in here, and it's a span of time. So the scale of the figure shifts from weeks to years as we continue through here. So there is a time frame shift as we're moving through here. Just something I want you to recognize as you're looking at this. There is typically a big window of time within here where uh, we see this latency period where symptoms are quite likely virtually non-existent, and that possibly sets the stage for concern with that for likelihood of transmission unknowingly, and that's an issue. There are other possibilities with this, and with this pattern, if we were to throw treatment into the mix as well, as far as what you might see occurring. So uh, this is the progression of the CD4 T cells, so those T helper cells in blue. And then in red is the HIV, so the viral RNA and the potential to detect that in the blood. So over here on this side is RNA copies per milliliter of plasma, so sampling it out of the blood. And on this other side would be for the blue, so the CD4, the T helper cell count in cells per millimeter cubed. So as we look at this T cell population, RNA counts, and then time, again, on the x-axis. So as we start with this figure, with the primary infection, as this first happens, we can see we've got high levels of T helper cells, the CD4 cells. We've got low level of detectable RNA copies. And it takes, so at time zero, this point right on here is the initial exposure or infection. It takes a couple of weeks before we start seeing any sorts of issues. It takes a little bit of time for the HIV to get in and replicate a bit. It's kind of like a bacterial growth curve where you see a kind of a period, a lag period, where that organism is getting established. So it's kind of the same idea from time zero to maybe about 2 weeks in before we start seeing, uh, excuse me, like measurable or detectable levels of this RNA in the plasma. And here, giving us kind of a little blip on the radar right here. And as we look at this, the level of T cells as we start exhibiting this first bit of growth within there, the T cell population starts to decline at about this same time period, and we see them crisscrossing right here. So during this point is acute HIV syndrome. We see rapid replication of the viral particles, as you see a spike here in this red bar, peaking here at about 1 million copies, 10 to the 6 RNA molecules per milliliter of plasma. So it's an enormous amount. And at the same time, the T helper cell population declines dramatically, almost by 50%, maybe a little over 50% at this point, down to about 500 cells per cubic millimeter. So a considerable decline. And at this point, ill effects are definitely exhibited. Some flu-like symptoms. You start feeling definitely under the weather, something's going on. And at this point, like I said, there's large amounts of virus within the blood. So the potential for, I guess, recognized as being really contagious at this point should be obvious because of the high level of virus. And we would call that viremia, lots of it recognized within the circulation. So at month and a half or so, we're at about 6 weeks here, we see kind of a spike with the level of RNA, and then it starts to decline the littlest bit over the next few weeks. So dropping down, a couple, 3 months into it, we hit levels that remain pretty stationary at about 300, or sorry, I'm looking at the wrong side over here. So over here at 10 to the third, so this is logarithmic scale. So we're up here at about a couple hundred thousand cells uh, or copies per milliliter of plasma, and it stays like that again for a handful of months, or potentially persisting for years as we move over into the year range. I mean, you can see it starts to increase over time. And again, as we're moving through this, this is looking at it without treatment, what is occurring. All right. So over this course of time, the level of CD4 cells, the T helper cells, kind of comes back. They don't come back to their original values, but they bump back up a bit. And then we see them starting to decline as their cell counts decline and the copies of RNA start to increase a bit. We see, just as we see them crisscrossing over here, the same sort of idea happens a few years in to the infection, where the T cell and RNA levels shift positions. And this is when we start seeing ill effects and the potential to start moving out of this latency period and really start seeing symptoms. And at this point, we shift really from talking about HIV to the point of AIDS. And at this third period, as we're moving through this with the symptoms, it's really as the immune response. These T cells have broken down considerably to the point that we're not able to detect other infections, to deal with, dictating what sorts of an immune response we should be dealing with any sorts of infectious agents. And we see a multitude of things plaguing these individuals, handfuls of infections that we've already kind of mentioned, where, if you have a weakened immune response, these are bad news. And if you've got a competent response, maybe you don't even, you're asymptomatic. You don't even recognize any ill effects whatsoever. So this is these opportunistic diseases. All of these things that may, in a normal individual, cause no problems are really what lends to death in this individual. And the level of HIV in the plasma spikes back to these levels that we saw early on in the infection, and the potential for spread at this point is much greater due to the high level of viral copies that are present. So as we think, with treatment, we can keep the blue, the CD4 cells, we can keep those levels prolonged high here, prolonged periods of time, and the red, the viral copies, we can keep them low for a considerable amount of time as well, pushing this from years here, or a potential decade, maybe to decades, maybe levels that are virtually undetectable, and the likelihood of transmission at these points would be very, very small. Some speculate unable to pass or transmit that infection. So it's likely that that is accurate. I think many are a little reluctant to say that that's the case. Let me stop that real quick. I want to shift over and share not the PowerPoint. This guy, okay. You should be seeing this table now. So like I said, there were a handful of viral infections, and some of this, it's just like, oh well, we don't really have a very good image, maybe, I don't know. I question some of that. Some of the details expressed in the PowerPoint are a little bit lacking. I feel like we could have still had some of these put in there, but that's okay. I'm putting it in there as I go, and that will work. So We hit HIV just 1 second ago, and as we look at this, there are definitely potentials dependent upon the stage of infection. Like I said, a few weeks into it, you start seeing flu-like symptoms, and then they persist for a few weeks and then start to decline. And in this point of latency, you feel pretty good. It's not toward the tail end where the immunity breaks down that we start experiencing the last bit of this, the period of AIDS, where fever and all sorts of issues start to be expressed. So, transmission with this is contact with bodily fluids, sexual transmission, and sharing of needles sets the stage for contracting HIV. There are handfuls of tests and treatment. We're seeing numerous advances with treatment with antiretroviral therapies, again, lending to virtually undetectable levels within the serum. We started today with Burkitt's lymphoma, Epstein-Barr, again, a type of herpes, herpes 4, and dependent upon circumstances, does set the stage for, uh, well, the Epstein-Barr for Burkitt's lymphoma in certain circumstances. There's also the potential for oral hairy leukoplakia, and this can be a fatal occurrence if it's not treated promptly. So body fluid contact with this saliva, blood, and semen, and individuals that are compromised HIV or malaria, which is a really, when we think about Burkitt's lymphoma, it's a good one with little kids. Malaria targets, anybody, but little kids are pretty good at contracting this, and with a developing immune response, and then that sets the stage for Epstein-Barr and Burkitt's lymphoma. So kind of just depends on the circumstances. The next few we kind of skipped over in the lecture. We'll hit right now. Chikungunya fever. This virus causes fever, as the name implies, rash and joint pain. It's transmitted by a couple of different mosquitoes, and with that, we can detect antibody. We can do viral culture. As far as treatment, there are no forms of treatment with this. A self-limiting infection. Cytomegalo is another herpes 5, also asymptomatic, but it can result in some Epstein-Barr like non-Epstein-Barr, but Epstein-Barr like mono that you can see in adults. So body fluid transmission, there's potential for the mother to pass it on to the child as well. Dengue fever is also described as break bone fever because the bone pain that's experienced typically with this is so severe that the patients describe it as if their bones are broken. They're pretty sure that they must have a broken arm or broken leg because of the severity of the pain. So handful of different dengue viruses that establish this, and numerous types of symptoms besides the pain in the bones, fevers and headache. It's also similar mosquitoes, Aegypti and albopicus, that can transmit this, and there's no reason that these mosquitoes aren't capable of transmitting both types of viral culprits simultaneously. That's a little bit disturbing. And then you got to weed through what are you really dealing with. Ebola virus, we saw that in the PowerPoints. Fever and headache, joint pain, the vomiting and hemorrhaging, which is truly some of the big concerns with this, set the stage for it being very contagious. So contact with any sorts of fluids, and you can see here again with the majority of these, no treatments. Hantavirus, this is something that's kind of close to here. First, really kind of talked about. I want to say it was mid 90s, 1990s, when around the Four Corners area in Southwest. where we saw some infections, some crazy infections that we weren't quite certain about what was happening, and then tracing it back to the feces from some rodents that feces or urine that coming in contact with the particles caused the infection. So this virus causes flu-like symptoms, and then you get worse progression with pulmonary edema, hypotension, lending to potential shock and fatal outcome, possibly. Um, so you know should be a recognition here that coming in contact with this stuff, you ought to be cautious. And if you are tasked with trying to clean up some of this stuff, you do want to use caution. Squirt some 10% bleach solution on it. Trying to sweep it or vacuum it up is ill-advised. Soak it with a little bit of bleach solution and then wipe it up to prevent it from being aerosolized. I don't want to tell you how to clean up mouse poop, but you should be careful. Hemorrhagic fever with renal syndrome, also the hantavirus, so it's another stage or step with that. So targeting other sites. So same idea, contact with the feces, fever and headache, nausea, and then the latter progression with hemorrhage and kidney failure as a result of all of the issues. Mono, Epstein-Barr virus and cytomegalovirus, so two different herpes viruses that have the potential for mono. And it is something that's really pretty contagious. It's oftentimes thought of as a high school or middle school ailment, where a kissing disease they call it, but it doesn't have to just be targeted to them. But usually that's when we see more issues and severity of infection. Pharyngitis, fever, extreme fatigue. You're going to be missing some school and potentially weeks of it, and that's definitely an issue. Yellow fever. We started this whole chapter, I believe, with yellow fever and seeing the individual with the severe jaundice. So dizziness, fever, and chills, all sorts of other symptoms, but liver involvement is maybe one of the main indications as that you've contracted this. So it can oftentimes described as asymptomatic or very mild infection, but there are some exceptions where it can be very severe, lending to hemorrhaging, shock, and possibly death as well. So there is potential transfer from primates to humans, or we can see transmission through mosquito vectors as well. Okay, let me stop that. And let's see, back to this. Okay, so shifting now to not that the viruses aren't fun and interesting, but shifting to the parasites, always a pleasure for me. So there are a handful of parasites that we want to think about the littlest bit, and I don't want to get too bogged down with this and go off on tangents, but I do want to work through this so you've got a little bit of an idea about what's going on. Plasmodium is the parasite that causes malaria. Malaria is a disease that has plagued humanity since the dawn of humanity. And with that, we have seen numerous uh, very interesting things with our evolution and the evolution of the parasite. We say, when we think about some of these things, that we've co-evolved together, and the parasite shaping some of the development of different variations within blood groupings, and we also see the development of that shaping differentiation of different genera or different species, excuse me, of the parasite with adaptations to uh, whom they potentially prefer to target. Mosquitoes don't care if they feed on anybody, but the likelihood of Plasmodium being able to infect the cells, well, there's definitely variation with that. All right. Uh, so there are a lot of things happening here. We'll work through it real quickly. There are two different hosts for the Plasmodium parasite. The mosquito serves as a definitive host, and in when we think about this, this is where sexual reproduction is occurring with that parasite. Wherever that occurs, that's the definitive host. We see ill effects in us, and extreme issues, but that doesn't, just because that's, it plagues us, doesn't mean we're the definitive host. All right. So the mosquito's the definitive host. Sexual reproduction happens within the gut. The parasite migrates up into the salivary gland. The sporozoites are basically the baby parasites, and they're injected through the saliva from the bite of that mosquito into our circulation. As that mosquito takes the blood meal and inoculates the parasites into us, within the circulation, they migrate. There's some specific things that help them uh, do this, but they migrate to the liver, and they take up residence inside of the liver cells, the hepatocytes. So we call this the exoerythrocytic cycle, or excuse me, yeah, it's not inside of the erythrocytes. So before we get in there. So exo or pre-erythrocytic cycle happens in the liver. The sporozoites get in, they infect, they start replicating asexually. So a single sporozoite replicates multiple times to produce many new parasites. So in the process of replicating, we get this schizont. It's a cell of multiple dividing Plasmodium. And within that are the new Plasmodia. We call these guys merozoites. The merozoites are released from that liver cell as it basically fills it up with all of the progeny. It causes that cell to lyse. The bulk of these guys are going to enter into the circulation. There are a few of them that will remain in liver cells. That's another story. So the plasmodium gets into the blood cells. This is the erythrocytic cycle. This is when we start seeing disease. All right. So here's one of these merozoites, and then it infects a red cell. There's some details with the parasite that allows its penetration and proliferation inside of the cells. Again, that's another story as well. So the parasite gets into the red cell, starts replicating. As it starts feeding on the red cell, we see this ring stage with a little vacuole, and it's degrading the hemoglobin inside of this red cell. It develops into this mature ring stage where it's going through, again, like the liver cell, numerous asexual replications, forming the schizont. The schizont has within it replicated cells, more merozoites, and those merozoites fill up this red cell, uh, causing it to rupture. The merozoites released out into the circulation to go on and infect more red cells. All right, that's the cycle of malaria in the blood, and it's this point when we see those the ruptured cells, the release of the merozoites. When they're in the circulation, we would call this a parasitemia. Parasites in the circulation where antibodies are able to recognize, and the details of malaria, the symptoms, excuse me, the symptoms are expressed, fever and chill cycles, right? That parasite really pretty quickly after it's released finds a new red cell and penetrates in, and the cycle continues. Once it goes into the red cell, Now it's cloaked, it's hidden from our immune response, and the symptoms subside. Most species of malaria give you, a cycle between 2 to 3 days of fever and chill cycles, with 12 hours to maybe pushing it toward 48 hours of reprieve, if you will, where the fever breaks, you go back down to normal temperature and you feel okay. But again, only for a day or so, and then back to the fever chill cycle. So it's kind of a vicious cycle moving through there. There are, quickly moving through this, numerous times that we go through this where we're replicating these cells and infecting more red blood cells. After a handful of these replications, then, and it's kind of, really like trying to get the populations up high enough in the first place. Some of these cells, as we've gone through here, shift, and instead of proliferating asexually, they develop into the gametocytes, the reproductive cells that will be transmitted on to the next mosquito. So it takes a few rounds of these replications to get populations high enough to stimulate the reproductive cycle in the first place. Once these gametocytes are generated, if they're not ingested by a mosquito, our own immune cells recognize and destroy them. They've got almost 3 days of survival in the circulation. And if they're not ingested by a mosquito, they get destroyed. So they can't turn around and be like, oh, there's no mosquitoes here. I guess I'll just get into a new red cell and continue to replicate. It doesn't happen. All right. So these gametocytes are the reproductive cycle for the sexual phase. The mosquito feeds on our blood, ingests these gametocytes, and within the gut of the mosquito, fertilization occurs. The male gametocyte, we call him a microgametocyte, exflagellates, so flagella emerge. It migrates quickly toward the female gametocyte. We call that a macrogametocyte. Fertilization occurs. You get a zygote that goes through mitosis, generating these sporozoites. We penetrate, the zygote penetrates through the gut of the mosquito and migrates up into the salivary glands. And that's where these sporozoites are ready to go, and the cycle continues. All right. So it's this blood stage where we see the ill effects. And malaria is, something we don't really think about in the United States, probably definitely not in Idaho. It's, something we did have in the United States. The Anopheles mosquito harboring the parasite was here. And then in the very early 1900s, through mosquito eradication efforts, we were able to get rid of it. That being said, that species of malaria carrying mosquito is back in the United States. It is yet to be seen or documented to transmit malaria, but I feel deep down it's just a matter of time before those mosquitoes feed on somebody that's harboring malaria, and we start talking about it here again. So this image is a blood smear from an individual infected with malaria. As they get in, as I showed in the previous slide, they form this ring stage or ring form. It's a trophozoite where it's actively feeding and dividing inside of that red cell, all right, creating the schizont, where it's got multiple rounds of division occurring to create the baby parasites, if you will. This image is of Plasmodium falciparum. It's the most dangerous of the plasmodia. It's the most common. It's highly infective, targeting any aged red blood cell, causing serious concerns and issues. So there are a handful of species of Plasmodium that plague humans. There are other species that plague other animals as well. And for those targeting us, there are various types of red cells or stages of development that they may target. And so you can see differing symptoms as a result of that type of infection. Um, Not exactly sure, but I think I'm pretty close to an hour into this, or 50 minutes. So I'm going to quit with malaria. I feel like that's probably a good stopping point. It was probably a better stopping point with all of the virus. But I'm going to quit this lecture right here, and we will pick up the next bit of this, the tail end of it, um, on Wednesday. Thank you all. Have a good day.